Thank you, SLUM, for partnering with us. And today, welcome all of you to the Academy of Nutritional Sciences. I hope most of you all had joined the program yesterday as well. And if you have missed it, the program is uploaded on YouTube, so you can watch yesterday's program on YouTube if you have missed it. Yesterday, we spoke about chemotherapy and uh, diet. Today, we are going to talk about something that, I think most of us know a lot already, and, we have been speaking about it, and there is so much of noise with regards to proteins. However, when it comes to proteins, as a nutritionist or as a dietitian, you all need to know, or we all need to know a little more beyond what normal or what other people know, because we need to know the science of proteins, and we need to know the science of protein turnover in our body. Once we understand the science of protein turnover, there will be a lot of aspects that will be clear in our mind when we are prescribing. So, however, today I request you all that stay muted till the lectures are on. You can flood with lot of questions. In case if I miss any questions, I don't mind you at the end of the session. After it's over, you unmute and you ask me. That's also okay. However, I'm going to divide this talk into two parts. One part is where I'm going to talk about amino acids and their role in protein turnover. The other part, I'm going to talk about the protein turnover in our body. When we talk of amino acids, when we talk about any supplements or we talk about giving proteins, we understand that protein is whole protein and it has different amino acids inside it. We have essential amino acids, non-essential amino acids. I'm not going to into all that because that is basic knowledge which everybody of us knows and has understood it. What I'm going to speak about is in the first part, I'm going to talk about how amino acid can be a driver or can be a game changer in your strategies towards getting the patient well again, and how you can choose amino acid to be a part of patient care. So that is what I'm going to be talking about. The second part is going to be a little more different in terms of what is protein turnover, what are the different aspects of protein turnover, etc. So, if you cannot hear me for any reason, you can ping me on chat. But I would suggest that everybody's device is different. So, if it is possible, and if you have AirPods or headphones with you, please plug that right away and listen to the lecture with the AirPod or your earplug on, because it will make a lot of difference for you to understand what I'm saying. And we can have a discussion post this. Yeah. So, whilst I just play, if you're able to hear what I'm saying, just give me a thumbs up once I start playing. Yeah. Thank you so much. Patient. Now, to, to talk today
to talk today. And I'm Dr. Eileen Canday, and critical care nutrition expert who's going to speak a little bit on how we can manage tolerances. So today I'm not going to talk about the different types of tolerances, but I'm going to talk about what you can do in order to choose the right formulae for preventing any kind of intolerances. And therefore, today I have taken up certain aspects of the formula which you can choose in order for your patients to have the least intolerances. So, coming first to the elemental nutrition. Now, this is designed for patients with probably a severe gastrointestinal issue, or is a critically ill patient, or has a complex metabolic need. So the elemental formulas, these deliver proteins in the form of free amino acids or smaller broken peptides, so that they are able to consume the simplest nitrogen sources available. So free amino acids require no enzymatic digestion. They bypass the functional pancreatic or the brush border enzymes activity entirely. And this characteristics makes these formula a critical tool in managing the patients who cannot tolerate standard enteral nutrition due to maybe it's a mucosal damage, or an enzymatic insufficiency, or inflammation that has compromised the gastrointestinal tract of the patient. Now, this characteristics also is very important in when you are choosing the right formula, because an elemental formula is a critical tool in managing the patients who cannot tolerate because of the mucosal damage. Maybe they have an enzymatic insufficiency, or that they are inflammatory, because of that they have compromised GI tract. So therefore, it is important for them to understand. Now, this there is a direct absorption in the proximal intestine. So these free amino acids are absorbed directly via the active transport mechanism in the proximal jejunum without actually requiring prior hydrolyzation. And therefore, the candidates for this population are people who are severely GI compromised, or they have mucosal damage, or they have a short bowel syndrome for that matter. So the rapid efficient nitrogen delivery supports these positive nitrogen balances in these patients. Then these free amino acids, which are the small protein units, they are carried by a minimal antigenic potential. That is an important characteristics when you consider patients with immune mediated GI conditions or any heightened mucosal sensitivity. So these amino acids are, they support the enterocyte, they support enterocyte regeneration and improve the mucosal integrity. So basically, when we are talking about reducing the antigenicity or the mucosal recovery, when we're talking about like what is antigenicity, it means that it's the ability of the substance to trigger an immune reaction in the body. So, large or complex proteins can sometimes be recognized as foreign by the immune system, and they may just aggravate the gut inflammation. So, when you say a free amino acid, they are small building blocks of proteins because they are broken down into the simplest form, and they are likely to less trigger the immune response in the digestive tract, and this is called what we say as low antigenicity. Okay, now this is very helpful in patients when you find their intestinal lining mucosa is damaged, inflamed, because the gut cannot absorb nutrients without any additional irritants. Okay, so these amino acids, they help in repairing, regenerating the intestinal cells, what we call as the enterocytes, and they improve the strength and the healing of the intestinal lining. Now, in certain clinical situations, where is it helpful? So, if you take a patient with short bowel syndrome, yeah, whether a large part of their small intestine has been removed or cut, or it has been damaged, so the surface area of absorption becomes very little or very small. Now, because the free amino acids, they don't need the digestion which a whole protein would require, they can be absorbed very quickly with the limited intestinal surface area that they have. So they don't have such a long surface area which other people have. So in that limited surface area, it is more so it helps these patients to receive adequate nutrition. Then there are some patients with mucositis, or we can say the inflammation to the damaged mucosal lining. It could be chemotherapy, radiation therapy. Sometimes certain illnesses itself cause mucositis. Okay, so these amino acids, they are gentle and they are non-irritating for the intestinal linings, which are very, very sensitive. Okay, the other good candidate for elemental nutrition is patients who have inflammatory bowel diseases, maybe Crohn's, ulcerative colitis. Okay, they cause chronic inflammation of the intestine, these intestinal IBD. And when we say IBD, these free amino acids, they have a low antigenicity and they reduce the chances of stimulating the immune system, and therefore they help to decrease the gut inflammation. Even in patients of post-operative recovery, that is, if they have undergone an intestinal surgery, you know and this gut needs time to heal and to adapt, so these are the right candidates whom you can offer an elemental nutrition. You can offer free amino acids, and these elemental nutrition, they support the healing of the intestinal lining. They do maintain the gut function, and they prevent, and in the final aim of us is to prevent any muscle loss. So therefore, for people who are sensitive, they require lesser digestion, or they need easy absorption. Those are the people who would be a good candidate for getting these elemental nutrition or amino acids. uh, the differentiating factor is what I would say is the osmolarity, which is a key determinant of any enteral formula tolerance. So hyperosmolar formulas, they do increase the luminal osmotic pressure, and they draw the water into the intestinal lumen, and they could cause this abdominal cramping, bloating, or even in some cases an osmotic diarrhea. So there are many elemental formulas that exhibit an osmolarity value, and sometimes it may also exceed 600 milliosmoles, which may contribute to a gastrointestinal intolerance or interruption. And therefore, we need to give the osmolarity that is suiting the gut. So osmolarity, which is an important aspect. So when we say 300 to 400 milliosmoles, these is an isotonic relatively to human plasma. Now human plasma is 285 to 295 milliosmoles per kg, and this represents a substantial reduction compared with the other formulas who may have very high. So when you're reading your label, just take one glance of what is the osmolarity of that particular formula that you're trying to feed your patient. Okay, so anything between 300 and 400, which is very close to the human plasma, is something that you should be looking for. So lower osmolarity, they do improve the gastrointestinal intolerances or tolerances. They reduce the luminal osmotic fluid shift. Okay, these they do refuse the fluid shift. The other aspect, when you are choosing a right formula for people who are sensitive to the gut, is the MCT. We all are using MCT rampantly, and they have a unique metabolic property that distinguishes them from the long chain triglyceride. Why? Because they do not need the bile salts for mediating the micelle formation that can be absorbed when the pancreatic lipase activity is impaired. So, if the pancreatic lipase activity is impaired, they are the ones which we should be looking at, and they get transported directly to the liver via the portal circulation. Okay, so rather than through the lymphatic system, they go through the portal system. And this is what we have to remember, that in the liver they are rapidly oxidized, and they could be used. So MCT, they have these different properties that is very different from the LCT, that is a long chain triglycerides. Okay, they are hydrolyzed, absorbed more rapidly, they do not require bile, and these are some of the characteristics that we can see. Also that the MCTs, we just understood that they do not require, nor they require bile salts, nor they require a pancreatic lipase. They are directly absorbed into the portal vein. But now they are useful in medical conditions where fat digestion or absorption is impaired. So, I'll give you a situation, say pancreatitis. Now, in pancreatitis, there is basically the inflammation of pancreas, and normal fat digestion requires pancreatic enzymes. Okay, so here is where you can have the MCT help you, because you don't need the pancreatic enzymes. You have reduced stimulations for the pancreas, and therefore you're providing energy without worsening the inflammation, and this makes it useful even in both situations, if it is an acute pancreatitis as well as the chronic pancreatitis. Also, when you're talking about chylothorax, whether there is a lymphatic fluid that is rich in fats, that's a chyle leak, which accumulates, that in these situations also, when you want to bypass the lymphatic transport system, you can use MCT, this thing, fat as a source of energy or source of fat. Hepatic dysfunction patients with liver diseases, bile product and fat metabolism impairment, they too can be here. Also, you can use the MCT oils. So, or MCTs in either powder form, oil form, very various forms, or the formula itself will have, MCT as a source of fat. So you can choose your cases like cystic fibrosis, short bowel syndrome, pancreatitis, bile acid deficiency. Okay, these are some of the situations where you can remember that, here you would want to use MCT as a source of fat. When you talk about the source of carbohydrates, there are many sources of carbohydrates. The most common that is observed on, on the medical nutrition therapy boxes that we see is isomaltulose. Okay, we know that it is a disaccharide. It contains glucose, fructose linked to the alpha 1,6 bond. Now, the slower the digestion results in a gradual, sustained release of glucose into the bloodstream, and therefore we have to give a slow release glucose to the bloodstream, and therefore, you can use these kind of carbohydrates. Also, talking about the digestion and absorption in the small intestine. Remember that we talk about gastric intolerances, bloating, or gas formation. So there is minimal colonic fermentation which reduces this kind of gas production, and therefore its slow enzymatic hydrolysis produces low glycemic response and sustained glucose release. Okay, rather than a very quick uh, glucose release, and this property would be an advantage in the clinical context, because it will, it can reduce the stress, hyperglycemia, the insulin resistant, post surgical metabolic management is always better in this situation. Then comes to the enteral formula with, sometimes you want to choose your formulas with a low renal solute load, because you may find that, you're able to give everything to the patient through a particular formula, but that particular formula, which is like your best formula to use, may have a very high electrolyte content, and then you are stuck. So if you have some formula which also has these properties along with a property that will have a lower renal solute load, is always important, because it reduces the amount of water that is required for the renal excretion of these solutes, okay, these dietary solutes, and therefore they decrease the obligatory urine output, which, when combined with an energy dense macronutrients, they will allow, nutritional targets to be achieved even with a low total fluid volume. So, we always face this one problem in the ICU where we want people to have lesser volume and higher calories and protein. So, this is one thing which you can look at: low electrolyte load and concentrated feeding designs. Then, in a concentrated enteral formula, the energy density is important because it allows you to feed at a and deliver nutrients at a lower, lower formula and lower liquid, and the nutritional targets can be achieved even with a reduced fluid volume. And this particular is relevant in special conditions when you have uh, you know kidney dysfunction, you have liver dysfunction, some patients have ascites, some patients have a heart failure, or their ejection fractions are fluctuating, they have a restriction because there could be fluid balance even during mechanical ventilation. So these are some of the issues when you can use an energy dense formula. Also look at the other aspects, besides macronutrients formulas, you also look at the micronutrients which support the physiological process. It could be an anti-inflammatory signaling, it could be intestinal, something that helps the intestine. So there could be many things. One of the aspect that I found particularly very useful is the role of DHA and ALA. So whether it is anti-inflammatory action that you're looking at or neuroprotection that you're looking at, these are two important bioactive nutrients that influences the formula sometimes. So look at the amount of docosahexaenoic acid or the alpha lipoic acid. Both play a very important role in reducing the inflammation and protecting the cell from oxidative damage. Okay, so these two, yes, you could be worried about the vegetarian source or the non-vegetarian source. Take a look at what from where the source is coming. Okay, whether it is DHA, that is the omega-3 PUFA, or whether you're looking at it from the algae source or another vegetarian source. If your patients are very particular of vegetarian sources, we do have a lot of patients who are particular for giving them from a vegetarian source, and therefore we take a look at the source from which the DHA and the ALA is coming. L-glutamine is always been a controversy, but remember that it is a free amino acid, and it is available in the body, in abundance, and it serves as a primary metabolic fuel for the rapidly dividing cells, especially the enterocytes and the immune cells. So when there is a period of severe metabolic stress, especially for patients trauma, critically illness, here the endogenous glutamine stores may become depleted. And if it is an essential amino acid and you're endogenously producing less glutamine, it is obvious that you need to give it from outside. So in these situations where you need an exogenous supplementation, do consider looking at the glutamine levels also of the supplement. Besides that, besides glutamine, we also look at the hepatic and cellular signaling nutrients: taurine, inositol, choline. Okay, these are bioactive nutrients which support the mitochondrial function, antioxidant defense. Basically, inositol participates in the intracellular signaling pathway. Okay, and also together these nutrients contribute to the mitochondrial metabolism as well as the hepatocellular integrity. So these are required for the cell functions. Of course, you can go on, but some of the important other nutrients which I have found of great usefulness when I am choosing a right supplement is lycopene or beta carotene, which are antioxidant, very powerful carotenoid antioxidants. They protect the body from oxidative stress, chronic disease. Especially lycopene is noted for two major conditions. One is cancer and cardiovascular diseases. Okay, so as we know, it is a precursor of vitamin A. Of course, eating a balanced nutrition is important, but when you're giving it through the tube or you're giving it through the powder, through reconstituted powder form, you have to look at these two aspects also. Because when we talk about immunonutrition and metabolic recovery, we'll talk about L-carnitine, selenium, and other micronutrients. This thing. So these basically are an entire ecosystem that will help and take care of your immune nutrition as well. Thank you for listening to me, and thank you for Academy of Nutritional Sciences for allowing me to give this lecture and this talk on a very useful topic. I'm sure it will help you. If you need to know more, please do get in touch with me. Follow the Academy, as well as if you need to buy some of my books, which I've written on swallowing, also on transplant nutrition, and on vegan recipes. You can get in touch with me or just message me.
Yes. So, okay, the talk is not over. We just these are some of the okay. You can hear me? Right. So this was the part one of the talk. Now we are going to have another aspect where I'm going to be talking about protein turnover, and that is the part two of the lecture. Just allow me to share my screen, and if you can hear me, I would just appreciate a thumbs up. Yeah, just a minute. Hi, today we're going to talk of protein turnover and metabolic control. Basically, to understand the dynamics and the balance of protein synthesis and degradation in health and disease. So, your body is not a static structure, it is living, breathing, where proteins are constantly demolished, rebuilt, and nutrition decides whether you grow strong or whether you go weak. So, protein turnover refers to the continuous breakdown and rebuild of the proteins in the body. Even you probably are not doing anything, you're just sitting down, and your body is still moving whilst the old damaged proteins are removed as the new ones are synthesized. So, this dynamic balance between the protein synthesis and the protein breakdown determines whether you are in a positive balance or a negative balance. So, positive balance especially will enhance growth and recovery, whilst in illness your body can go into negative balance. It could be illness, starvation, trauma. Okay, for a healthy adult it could be a neutral balance, and therefore metabolic control refers to how the hormones, nutrients, and your physiological states regulate this turnover. So every day your proteins are recycled into a new, old, and new protein synthesis. So this basically, if I give you an example, people who go to the gym, who lift weight, what happens? Their muscle fibers get micro tears, and the body increases the synthesis when they have a protein rich meal. Okay, so if you do not eat enough protein, we know that the breakdown continues, the synthesis is insufficient, and there is no more muscle synthesis. So let's go ahead with this talk. Now, what are the general principles governing continuous protein synthesis and breakdown? So, protein turnover is a constant regulated process which the body proteins are synthesized and degraded. One is to maintain the cellular structure, function, and adaptation. So, even in a healthy adult who's at rest, that's not doing anything else, about 250 to 300 grams of proteins is turned over daily. Okay. However, when you eat how much? 60 grams to 80 grams of proteins, okay, which comes from the diet. Now the rest is a recycled. So what is the basic dynamics is that there's a dynamic equilibrium. So it's a simple math. The net balance is equal to synthesis minus breakdown. If it is growth, pregnancy, recovery, it is a positive balance. It is a starvation, trauma, sepsis, it is a negative balance. If you are a healthy adult, it is a neutral balance. So all amino acids, they circulate in a common metabolic pool that is derived, one, from dietary breakdown, okay, from dietary intake. Then there is tissue breakdown, and there is de novo synthesis, that is non-essential amino acid. So this is basically the pool that we are talking about. Okay, dietary intake, tissue breakdown, and de novo synthesis, non-essential amino acids. Now this pool supplies structured amino acids, structured proteins. They provide your enzymes, hormones, immune proteins, sometimes even gluconeogenesis. So remember one thing, that different tissues behave differently. So not all the tissues treat and behave with proteins in the similar manner. So there is liver, where there is a very rapid turnover, that is from the plasma proteins. The muscle is the largest reservoir. Okay. The other area where there is a very high turnover is your gut mucosa, and your immune cells rapidly responds. So these energy dependency comes from certain protein synthesis that requires ATP. Okay, and in synthesis, the energy deficiency, that is breakdown, prominates. So amino acids diverted for glucose production, protein metabolism, which is linked to the energy metabolism. Okay, so that's when we talk about protein turnover. Talking about the molecular mechanism linking protein depletion and morbidity and mortality. So basically there is different mechanisms, that is loss of lean body mass. Okay, that is when because there is reduced respiratory muscle strength, increased ventilator dependency, reduced morbidity. So what happens in a critically ill patient? There is immune dysfunction. So protein depletion does cause reduced immunoglobulin production, reduced complementary proteins, impaired T cell proliferation. Now this T cell proliferation, that results in a higher infection rate, and therefore it delays recovery. The other mechanism which is here very important is hypoalbuminemia. Low albumin, we have seen patients with edema, and we have related it to the low albumin levels, right? So there is, when there is a low albumin, there is edema, there is also a poor wound healing, and there could be a high mortality risk. Now we know that albumin is not just a nutrition marker, it reflects the systematic inflammation and protein synthesis capacity. So impaired wound healing is another aspect where the collagen synthesis decreases. So fibroblast proliferation reduces. We also find that in certain other metabolic instability, there is depletion of proteins, there is depletion of enzyme synthesis, and that is why in severe malnutrition in the ICU, which can lead to mortality. Okay, so if you consider that a man who is 65 years old is admitted in your ICU with sepsis, his cytokines are high, his cortisol is high, his insulin resistance is persistent, and there is muscle proteolysis. All this also leads to albumin decrease. Okay, and when you give calories only and do not give proteins, the muscle wasting continues and infection will worsen, and therefore the mortality increases. Now I would say that protein turnover is a continuous energy dependent, hormonally regulated process that does maintain the structure and function of the integrity of the tissue. Now dietary protein intakes, they are modified. One is by the amino acid pool size. Not only the amino acid pool size, but also the mTOR signaling, the nitrogen balance, the insulin anabolism, the glucagon adaptation, okay, all these things which help the balance that would otherwise lead to sarcopenia, immune failure, and organ dysfunction. Now, coming on to the protein turnover, which is described as a continuous process of protein synthesis and degradation. So, in a healthy adults, there is an opposing force of equilibrium. You know, when you're trying to maintain an equilibrium, one side you're synthesizing, so one side there's anabolism and one side there is catabolism. So, approximately, if you have a 300-gram protein which is daily synthesized and broken down, what happens, like suppose you're fasting overnight, okay, and you have eaten your last dinner at 9 p.m. in the evening, and in your sleep, so basically in the night you're not eating any dietary proteins, okay. So what happens is there is a slight muscle which is trying to break down. So that's why when we tell liver patients, CLD patients, that eat a late night protein snack, you know, because we want to prevent this muscle protein breakdown. And here in the night, amino acids are released. After you have eaten, the amino acids are released from the blood into the blood. The liver also uses some amount for its glucose production. uh, Also, you are not realizing, but there is synthesis of enzymes, transport proteins, they are continuously happening. So when you wake up in the morning, so visibly you have not lost any muscle, but there is a balance that happens over 24 hours. So when you eat a protein rich meal, amino acids are increased in the blood because there is increase in your insulin. Yeah, as soon as you eat, insulin also increases, and muscle protein synthesis increases. And after a few hours, if when you have stopped eating, there is no release of amino acid because there's no more protein that is coming in. So what happens is there is a decrease, and there is a decrease in the total circulating amino acid in the pool. So what happens also in certain, like suddenly you're cooking something and you have accidentally cut your finger, you know, so the old damaged proteins at the sides get degraded, and new structural proteins, you know, here we have learned in the clotting factors, you require collagen, you require fibrin, these are all synthesized. So immune proteins are produced, okay. So even though your total body proteins remain stable, there is an intense protein turnover. Now you understood why I said protein turnover is not equal everywhere, right? So it will definitely go now towards that cut on your finger which requires that extra collagen and fibrin. Also when you are exercising, so you are doing resistant training, and then you feel, you know, that you feel sore, there is a micro damage for your muscle fibers, and what happens to the old proteins, they get degraded, and what is synthesized here is new actin and myosin proteins, right? So can you imagine now that proteins in your body, in your day to day, you don't even realize that in day to day, once your proteins are getting synthesized at different times and at different levels, okay. So when you need, sometimes you need collagen, sometimes you need myosin, and sometimes you need actin. So you may not be critically ill, but you need amino acids, you need proteins, you need amino acid from that pool. It's like one bank, you know, you have kept your amino acids there, and suppose during the day you need it for your cut, for your wound, for your wear and tear of your muscle. So from that pool, it's like a small little bank where it goes. The bank is, say, the muscle, and it goes and asks, you know, okay, now please give me little collagen or give me little fibrin for my little finger that has got a injury, or give me some actin and myosin, or some amino acids, essential amino acid, because now this little boy is exercising and he needs to build up the muscle. So these are just small little daily examples, but remember that the liver, it's liver protein renewal is constant, where there is, and there is degradation of old enzymes. Liver is important, why? Because there is synthesis of albumin, that is happening here. And it also produces the clothing factor. How much is the albumin half life of 20 days? It is 20 days, and it's continuously synthesized and degraded. So even if you feel stable, your liver is continuously renewing your proteins. Okay, it's like scraping the old paint off and replacing it with the new paint, or just it's just that just as everything else in our house needs maintenance, even your body needs maintenance. So even if your building looks happy and safe, one day it will need painting, right? So in if you're taking 300 grams of so why do you need basically 300 grams? When we say protein turnover is 300 grams, and you're not eating 300 grams, and so your total body proteins, say if you may weigh, if everybody has a little different percentage of total body proteins depending on how much muscle you have, but if I would say 10 to 12 kgs about your, if you have 10 to 12 kgs of muscles, so about 2 to 3% is turned over every day. So that means if I say 2 to 3% would be about 300 grams, 250 to 300 grams. Okay, now you're eating 60 to 80 grams. So the rest is got from where? It is got from your internal breakdown. And this recycling efficiently happens, and this keeps that equilibrium. So now this equilibrium, remember, is not only the protein that is synthesized and broken, but it is also the hormones that are controlling it. Okay, so this, there is shift that happens because of the hormones as well. So this continuous cycle of protein synthesis and breakdowns allows the body to remove the damage and the excess proteins, while simultaneously it is producing new functional proteins for your growth, repair, enzymes, hormones, transporters, and immune molecules. So the circulating and the intracellular free amino acid pool, which is relatively small, it is not very big, 70 to 100 grams in adults, which is like one reservoir. So remember, when we talk about fats and carbohydrates, the body has a store, which is the store for carbohydrates, we all know, glycogen. And because muscle is the largest organ, so it stores more, and the liver also stores a lot of like glycogen. Okay, so therefore this amino acid pool must be constantly replenished. Okay, and the important thing is that if you consume 60 to 70 grams of proteins per day, which is required, there is a small amino acid pool which is sufficient, because amino acids are there continuously. But that is for if you're a normal healthy person. What happens when there is illness, trauma, burns, starvation? Then there is a balance shift towards more breaking down. So what happens is, imagine somebody is asking, "Arey, there is a lot of breakdown. Come on, give me more amino acids," and the reservoir is limited. It will keep on giving, but you are not replenishing it, right? You are continuously giving, which you're losing your muscles, because the your there is breakdown, which is leading to muscle loss. And here, because you're not able to replenish more, there is a negative nitrogen balance. Okay, so therefore when we talk about healthy adults taking proteins is a little different. When you talk about illness, trauma, I just spoke about that one finger prick where you need collagen, fibrin, you are doing exercise, you need myosin, actin. But what happens in a trauma? What happens in burn? Your body goes into a shock. Okay, you need proteins vigorously at that time, and that's when you can go into a negative nitrogen balance. Okay, forget illness, trauma, burns. What happens if you're pregnant? What happens if there is a 16-year-old boy who's doing exercise, he wants to grow muscles, but he's eating the same amount of food which everybody else is eating? Will he synthesize muscles then? No. He is just going to go on using up his glycogen and his fat stores without any building, because there is wear and tear. So when there is wear and tear, it will take amino acid from the pool, but it will not provide more till you give it through food. So therefore, if you want a positive nitrogen balance, it is important that you replenish your amino acid pool. So protein metabolism is very static. It is not that you give it one day and you sleep for another 5 days. It is tightly regulated. It is energy dependent. You can't just give calories. You have to give proteins as well. Yeah. So this is the basic cycle that we are talking about. Also, there are what are the hormones that are controlling this? A most important anabolic signal, which is produced by the beta cells, is the insulin. The triggers are increased blood sugars because you have eaten food, amino acids, and incretin. So, insulin in the body storage and building hormone. So, basically, carbohydrate catabolism increases the glucose uptake of muscle adipose via the GLUT4. Now, this is important to remember. Increase in glucose uptake happens via the GLUT4 and stimulates glycogen synthesis in the liver muscles. So what inhibits gluconeogenesis, and therefore there is decrease in blood. Now in the protein metabolism, there is increased amino acid uptake, stimulates protein synthesis, inhibits the protein proteolysis. There is also fat metabolism happening at the same time. So what happens is it promotes lipogenesis, inhibits lipolysis after you have eaten food, and then what increases your triglyceride storage, correct? So we know carbohydrates are stored as glycogen. Fat increases triglyceride and lipogenesis. But what happens in a type 1 diabetic? When there is no insulin or less insulin, there is hyperglycemia. So in this case, when there is hyperglycemia and there is no insulin, your body goes into a lipolysis, and hence there is ketone production. Yeah, we are aware of this. But here in terms of muscle, what happens to this? Especially in type 2 diabetes also, this happens when there is insulin resistance. So there is a compensatory hyperinsulinemia, visceral adipose tissue, and metabolic symptoms. So in the fed state, glucagon, which is a catabolic driver, that is from the alpha cells of the pancreas. Okay, beta cell is insulin, alpha cell is pancreas. The trigger is fasting or hypoglycemia or stress. So glucagon is basically known as a fast hormone, and therefore when we talk about an overnight fasting, glucagon rises, liver releases glucose and maintains the brain function. Okay, so therefore we get episodes of these with low insulin and high glucagon, and especially in DKA. Okay. The other important hormone here is cortisol, that is your stress hormone. So we know that the sources are adrenal cortex, that is the zona fasciculata, and which is regulated by the ACTH, okay, from the pituitary. So cortisol helps the survival of stress. What is a stress here? Stress is infection, trauma, surgery, maybe physiological stress. Okay, and the actions are carbohydrate metabolism, insulin protein metabolism, and fat metabolism. Here the immune system is also involved in stress, and therefore it is the anti-inflammatory and the immune suppressive responses also happen. Okay, so in severe infection, cortisol increases, and therefore we need to understand that there are other cortisol shifts that the body towards catabolism to provide glucose. For what? For survival. What happens in inflammatory cytokines? Remember in COVID we all spoke about inflammatory cytokines, inflammation. Now the metabolic disruptors, they cause the inflammatory cytokines like TNF alpha, IL-1, IL-6, and they are produced when there is severe infection, trauma, surgery, even sometimes obesity, chronic diseases. Okay, so these are the metabolic outcomes. Even in sepsis there is these outcomes in inflammation, where there is shift of metabolism towards breakdown, especially the muscle breakdown. So in sepsis also this happens. Post-operative patients, suddenly there is the stress response to cortisol has increased. In obesity and metabolic syndrome, there is a low grade inflammation that happens, and people come to you and tell me, oh, give me an anti-inflammatory diet, my CRP is increased, and all those things. So therefore we need insulin, we need glucagon, we need cortisol, we need these all things for a proper hormonal and to control this system. Also talking about the metabolism when you're fed. Okay, so what happens in when you have eaten food, the body continuously, the body is not all the time in an anabolism or all the time in a catabolism. It keeps on shifting, and this shift happens because of the availability of hormones, or the availability of proteins, I would say, and the availability of food. So they when you eat, it is basically the fed state when you have just eaten. Then is the prolonged fasting stage, or one is the fed stage, one is the early fasting stage, means when you have just not eaten anything, and the prolonged fasting, that's the starvation phase. So the first 4 hours after you have eaten your food, insulin increases, glucagon decreases, cortisol is low at baseline, and there is carbohydrate, glucose is absorbed from the intestine. The insulin stimulates GLUT4, okay, that is mediates uptake of muscle and adipose tissues, glycogen, and then what happens in fat metabolism, dietary fat transports they transport as chylomicrons. Remember, lipoprotein lipase activated by insulin. Then in protein metabolism, amino acid here is taken up by the muscle, so there is synthesis that is happening. So suppose you have eaten rice or roti and dal, vegetable chapati, the insulin peaks up, and then there is the sugars, the food is broken down after about 4 to 16 hours. Okay, when you're not eating anything, there is a switch. So what happens is, now the insulin starts decreasing, glucagon starts increasing, uh, there is a cortisol also which keeps on increasing a little bit. Means it's at baseline, but mildly there is increase, and there is the mild proteolysis that happens. Because why does proteolysis happen here? Because you have to supply amino acid to the pool, right? And now suppose the same thing, 8 to 10 hours you're not eating anything, what happens? Your liver glycogen, which maintains the glucose, the brain requires, right? And therefore these prolonged fasting beyond 16 hours will even further lower the insulin. The glucagon will even more be high. Okay, and it will also increase the cortisol accordingly. So when you want to preserve glucose for brain and RBC while switching on this tissue fat, this thing, early prolonged fasting, 1 or 2 days, you understand, when a person is fasting because of a self mediated fast, or because the patient is not fed. Okay, sometimes in the ICUs, in the hospitals, we are not feeding the patient, thinking that, oh, let the patient fast. But those are the most dangerous times, where the patient can have a depletion of the amino acids and breakdown of muscles. Yeah, it does happen even in religious fast, where there is prolonged stress, in diabetes, in obesity, in ICU. Some people do intermittent fasting. Okay, so the body is metabolically actually very very flexible, and it will respond to how much of food you are giving the body. Coming to the prolonged deprivation, whether due to starvation or illness, there is metabolic adaptation Okay, that automatically happens because you have to preserve life, right? So the protecting your vital organs is important, conserving protein stores is important. And in the early phase, that is 6 to 24 hours, once the exogenous glucose supply stops by the body from the fed state to the endogenous fuel mobilization, there is decrease in insulin, increase in glucagon, there is increase in, of course, not only cortisol but even catecholamines. Okay, so there is glycogenolysis because your brain, your blood cells, your renal medulla, they need glucose, right, to survive. They need glucose, and liver glycogen stores are limited. After some time, within 24 hours, they'll be typically depleted. So when the body has no more glucose, where will it go to? Obviously free fatty acids. Okay, so in 1 or 2 to 3 days, your glycogen is exhausted, and your body relies on gluconeogenesis. That is, first of all, glucose production happens because of new glucose which is synthesized. Now remember this, this is very very important for amino acid pool. Why? Because when we talk about gluconeogenesis, who is the neo? The neo is alanine, which is got from muscle protein, lactate from the Cori cycle, and glycerol from the adipose tissues. Okay, so and here when we talk about protein, we are talking about alanine from the muscle. So the muscle proteolysis increases the nitrogen losses. Urinary urea excretion also increases, and this phase is actually a protein costly phase, and in the long term it is very bad for your muscle. So these adaptive phases happen in 3 to 7 days, and it can prevent a fatal protein depletion. So the protein initiation and metabolic adaptation, ketogenesis also increases, where there is breakdown. You get free fatty acids, you'll get acetate, beta hydroxybutyrate. Then the brain which requires this, so ketones are supplied. Prolonged fasting, like starvation beyond a week, it's a fact that there are people who are staying even beyond a week of food, even in the ICUs. Okay, so the imagine what happens if it happens to a normal individual who's otherwise healthy. Imagine what happens to a patient who is in the ICU. Okay, because you're even the now the primary fuel becomes fat, the adipose tissues. Okay, the muscle breakdowns also slows down because there is no more to keep on giving. Okay, there is a change in your basal metabolic rate. The thyroid hormones also start conserving now. They decrease their T3 the T3, and they reverse to increase of this thing, the three reserves. So the energy expenditures, uh, basically clinically, if you look, a patient can develop bradycardia, hypotension, thermogenesis, lethargy. You see all these symptoms when you find a person malnourished or starving for many many days. We talk about fatality, or why protein starvation proves fatal. This is the reason, because it is not only a fuel for your enzymes, for your transports. Okay, or it's not just like depletion of fat and glycogen, but it causes structural changes. It Every cell depends on your proteins, your enzymes, your hormones, your receptors, your ion exchange, your structure, your body, actin, myosin, your collagens, transport proteins, your hemoglobin, your albumin. And when this all happens, there could be a continuous depletion even in your respiratory muscle. So if a person is on ventilator, there is a reduced ventilator capacity. There could be cardiac impairment, smooth muscles, especially of your gut. Okay, and this could be fatal. It could lead to death. Coming to the adaptation of low protein intake. Okay, so when we say adaptation of low protein intake, so it is the initial response, which is the nitrogen conservation, where the body starts reducing the amino acid oxidation. On, I'll go through the next slides, where all your body essential concepts of proteins that you need to remember. So all body proteins are structural and function. When amino acids are required for energy, the body must adapt. Skeletal muscle becomes primary donor, okay, because and during fasting trauma you need to definitely give more proteins to build up your amino acid aspects. There are some case studies which I can take you through. So this is a 35-year-old male which is admitted for burns after 45% total body surface area burns, and he's undergone a fluid resuscitation, ventilated. Within 48 hours he's developed hypermetabolic response. Okay, so basically here there is resting energy expenditures is skyrocketing about 180%. Rapid muscle wasting is happening. Albumin has decreased to 2.1. Pre-albumin is markedly reduced. The CRP levels are elevated. Inflammation is there. Nitrogen balance is 80 minus 18 grams per day. Okay, so pathophysiologically, major burns, intense catabolic state, hormonal and inflammatory drivers are markedly elevated. Okay, and now in this case there is an amino acid release from the muscle which is used here for wound healing, collagen synthesis, immune cell proliferation, acute phase resistant. So if you do not give an aggressive, remember what I'm telling here is aggressive protein replacement. If there is no aggressive protein replacement, there is an aggressive endogenous breakdown, okay, which is not similar to fat stores. Okay, there is respiratory muscle weakness, delayed wound healing, graft failure if the patient has undergone a graft surgery, and his ICU stages increases. Just as when we spoke about adaptation, there is a shrinking of the body. Similarly here the patient stays in the ICU, like, for a very very long time. If I have another case, yes, this is also very very significant case of a short bowel syndrome, where there is extensive removal of the small intestine in a 48-year-old patient, and approximately resection of 180 centimeters of the small intestine, and there was only 70 centimeters of the proximal jejunum and no ileocecal valve. Now when this patient tell me, are you going to give whole proteins? I'm going to wait. Okay, now the patient will go, the proteins will go for digestion, it will go into the amino acid pool, and then it will make muscles, and then it will break down. It does not happen that way, right? There is a high output jejunostomy for this patient. Can you imagine 2.5 to 3 liters per day? Plus there is diarrhea. This patient is losing 4 kgs in 10 days. There is tiredness. Patient is into hypoalbuminemia 2.6. Even the magnesium has dropped down. The potassium has dropped down. The negative nitrogen balance is minus 10. She is not able to tolerate even oral. How will you feed such a patient with a short bowel syndrome? And that's when you look at, you are desperate to feed this patient something that the patient will assimilate, tolerate, and come out of this situation. And that's when you are looking at replenishing these high protein losses, and you want to give an essential amino acid through a supplement. And to you whilst you want to feed the patient well, you may not be able to feed that much amount because the patient is having diarrhea, the patient cannot eat adequately, the patient is tired, weak, and there is loss of lean body mass, there is delayed wound healing. So here you have to remember that you have to give, sometimes in such situations we also give TPN. Okay, and if we cannot this thing, we along with an amino acid rich formulation, both are given. And you also look at the hydration, you look at the electrolytes track. Now you will tell me, oh, we'll give amino acid only for a patient in the ICU or patient who has got short bowel syndrome or burns or trauma. I said no, you look at a normal individual also. He is doing competitive endurance athlete, he has functional protein deficiency. He's progressively tired. He's there, plus there is weight loss for him, although he wants to build up muscles. Okay, then if you look at his serum levels, his albumin is not anything great, uh, ferritin is not anything great, it is low. Okay, and therefore he may be training a lot of training, he's doing 90 to 100 kilometers per week, strength training, eating well, calories also, but look at his proteins, 0.8 grams. How will it sustain him? How will it make him have good muscles? How will it make him stimulate protein synthesis? Not possible. So here in these cases also, when we want, like, the endurance training to increase, or we want a muscle repair to happen, we do give proteins, because here it elevates the cortisol, it reduces the mTOR signaling, it impairs, it helps the immune system. uh, we can give up to 1.6 grams of total proteins. Of course, you can adjust it, but one thing here is very, very essential is the leucine rich post workout amino acid supplement. So when you are giving a supplement, look at the quantity of leucine that is present in it. You can add 10 grams of essential amino acids post training. You can distribute it in the 4 meals. You need not give at one time. Yeah, remember we spoke about the pool, and that's why your amino acid supplementation is also very important. Yes. So hi everybody. Thank you for listening, and fine. I have some questions in the chat box which I will answer, and then if any one of you want to ask certain questions, either you can unmute or you ask in the chat box. Both are okay with me. I would like to interact with y'all, so that would be good. Okay, so let me just check if there are questions. Okay. Okay, what is the one thing that makes elemental nutrition different? Okay, so when we talk about elemental nutrition, we talk about something that's already pre-digested, or something that's already, the work that has to be done a lot by our enzymes, and our digestive capacity outside is done inside the body, is already done outside the body. And I think that is what is important in an elemental nutrition. So in an elemental nutrition, we not only look at proteins, we also look at MCTs, we look at fat, we look at carbohydrates, we look at every macronutrient that has been pre-digested or that has been broken down in order for the gut to absorb it easily. So that is the meaning of elemental nutrition. Chandani, yes, you missed the osmolarity, but nothing to worry. The YouTube will be available for the next 2 days. So if you want, you can go back and check it. It's a very simple thing. Try to give foods that fit the osmolarity and closer to the blood plasma osmolarity, so that there is no osmotic diarrhea, or there is no shift of fluids from one to the other cell, because of which there could be edema or any other issue. So that is one. And thank you, Rita, for that heart. Okay. Does anybody, before I end the session, does anybody have any questions, queries to ask? Okay. Yeah, Chandni. Thank you for the hearts. Thank you, Richa. Uh, Actually, I wanted to tell you all one thing, that I am going to be having a series of webinars for critical care nutrition. And that is going to be mostly from the 23rd to the 27th of this month. If you all are interested, please do join in. I will be sending the details shortly. It is a small advanced nutrition, critical nutrition, which where we'll be covering both enteral as well as parenteral nutrition. Very interesting topic. Something I know, sometimes we find it boring when we have to do something in advance, because that's not what interest us. Because when we want to do, we want to understand protein turnover. In fact, I myself was saying, oh, is it so boring? So, but when talking about like interesting things, then we say that, oh, I want to listen to this. But sometimes we have to listen to the little boring things in order to understand the science of a certain aspect that we're looking at. And exactly what I'm trying going to do is I'm going to be talking on critical care nutrition, the different aspects, like what is indirect calorimeter, how do you manage tolerances in patients, what are the substrates of parenteral nutrition, what can you give in enteral and parenteral nutrition. I also probably plan to put a home parenteral nutrition because that is coming up a lot. If even if you're not a hospital dietitian, I think it is very good that you could join in and be with me. We could also have some discussions. Yeah, and I thank all of y'all for your lovely hearts and the things. Thanks, Agastha, Jayashri, Satya, Sapta, Anjali, Shweta. Yeah, thank you, all of you. And I believe that y'all have no more questions. And can before I end this, I just really would like to thank SL Lume for partnering with this session. Yeah, you can go on to SL Lume and see what they have, because they have some interesting things. My friend Mayurika will help you out with the different aspects of, if you want to know something more about what products they have and the other things. Nevertheless, do get in touch with me if you have any questions with regards to amino acids. I use it a lot for my patients, and I have found that using an amino acid supplement or elemental nutrition is helpful for certain patients who really need it. When Why should we struggle with them when we have something? Yeah. So yes, Dr. Karti, we will be talking about the two-chambered bags in TPN as well. Yes, we'll be talking about the bags in TPN. That is in my critical care nutrition, advanced nutrition webinar, which is going to be happening on the 23rd. So do wait for the information to come in. It's going to be a little paid webinar because we have to pay for the platform, and we have to pay the people who actually work for it, but it's going to be a very minimal fee. Thank you. Yeah, so I'm going to end this meeting. Before I end this meeting, I would like you all to take a look.